Hello students. So today continuing our topic for bioengineering and ergonomics. We have already completed lower limb orthosis, moving forward to upper limb orthosis. So we'll be discussing briefly about the introduction to the topic, principles of orthosis, biomechanics of orthosis, classification, contraindications, disadvantages, and various upper limb orthosis. So today in this topic, we are going to see up to disadvantages. Only upper limb orthosis will be a separate topic, but many of the names, as you will see, will be incorporated in these topics of classification also. So first thing, what are orthoses? You are already aware the orthosis is a mechanical device fitted to the body to maintain it in an anatomical or functional position. Orthotics refers to the science of fabricating or fitting the orthosis. So the science which makes an orthosis is orthotic. Uh, Principles of orthosis, protection of an impaired joint or part by restricting the impaired joint, that is statically limiting the joint motion. Second, stabilize the unstable bony component and promote healing of soft tissues and bones as done for the fractures. Even POP can be considered as one of the orthoses. Second, correcting joint contracture, subluxation of joint or tendons, that is supporting the part, and assist in improving the function. So that is a dynamic orthosis function. We have also seen the principle of Jordan, that is 3-point pressure principle. The other name for the same is principle of Jordan. You already know uh, if a deformity is there, F1 will be equal to F2 plus F3. Yes, so the corrective force and 2 counter force. That will be total in the system of 3-point pressure system or principle of Jordan. Remember the name. Other name for 3-point principle is principle of Jordan. What are the biomechanics of orthosis? So it has direct and indirect biomechanics. Directly, it will control the rotational movements, minor accessory rotational movements, transitional forces, and axial forces. Indirectly, it will control the line of action of ground reaction force. So all the orthosis of upper limb will directly control the biomechanics by limiting the accessory joint motion like rotatory motion, transitional forces, and axial forces, and indirectly it will control the line of action of ground reaction force. These are the factors affecting the tissue response of orthosis. If biomechanics is to be changed, it will depend on two things. First is the intrinsic factor, second is the extrinsic factor. So first, intrinsic factor. So how the tissue will change, that will depend on which tissue we are targeting. So the tissue mechanics play an important role. You are targeting the muscle, you are targeting the ligament, you are targeting the capsule. What tissue you are targeting, that is an intrinsic factor. On this it will depend, the recovery will depend on this. And second, load transmission across the interface. If some part is freed from the load, so how will it behave? That is also intrinsic factor of the joint that will be responsible for affecting the tissue response. Extrinsic factor, once you have applied the orthosis, externally, is there any pressure? Is there any shear? Or is there any interface with the microenvironment between the orthosis and the part that you have aimed to treat with the orthosis? So, is there any interface with them? Is there any pressure or is there any shear? This will be all the extrinsic factor from the environment to the body part you have given orthosis to. Classification, moving forward on classification. So classification will be static, dynamic, adaptive, and continuous passive motion. Continuous passive motion orthosis, you are aware, they are electrically operated devices that moves joints in desired programmed range of motion. So it is similar to CPM that you have learned in previous semesters. Static, dynamic, and adaptive orthosis. We are going to see each one of them in a bit detail. So static is again divided into serial static, static motion blocking, and static progressive. Dynamic is divided into motion blocking, traction, and tenodesis. And third is adaptive orthosis. So first, serial static splint, that is a static splint, but angle of position is changed periodically. For example, in flexion contracture of the wrist with serial repositioning splint, the range of movement can be improved. So these splints to be given for specific position. Once they are maintained, a new range is gained. Again, increase the range, give a fixed cast, and then it will again improve the range. So, for example, in flexion contracture of the wrist, when the wrist is completely in flexion, give orthosis by doing some extension, maintain that position for few days or weeks. When it is relieved, then again go for extension, make a new splint or change the angle, and maintain that position. This is serial static splint, allows no motion but can be used to increase the range of motion. Second, static motion blocking splint, that it permits motion in one direction and blocks other movement. So if you can see the swan neck deformity, you already know what is swan neck deformity, that is hyperextension of the PIP and flexion of the DIP. So for swan neck splint blocks the hyperextension, allows flexion at PIP joint. So it will not allow hyperextension. See, it will block here hyperextension, but it will allow flexion. Yes. Then static progressive splint used to regain range of motion, again like the first. The joint is placed in a position of stretch, and once motion is increased, the tension is increased progressively. Yes, so same example if we take, if extension is not there, there is a flexion deformity in the elbow. If you can see this example, these maintain the range of motion, this maintains the static position. So increasing the lever here will increase the range of motion and bring the arm into extension. So with time, with days and weeks together, slowly and steadily, complete full extension at the elbow can be achieved through static progressive splint. Moving forward to dynamic motion blocking splint, first of all, utilizes the passive elastic pull in one direction and active movement in other direction. This allows to maintain the functioning of the unaffected group of muscle. For example, dynamic cock-up splint, active flexion and passive extension is allowed. So in wrist drop, that is radial nerve injury, when there is wrist drop, the extension is not possible. At that time, dynamic cock-up splint can be given. This allows active flexion. The patient can do flexion, but extension is passive, and the extension is through springs or wires attached to the splint, which does not allow the motion or does not allow the wrist to remain in flexion. It pulls back into extension. And against force, if you do flexion, it is possible, but as soon as you leave the flexion force, the hand will go into extension. So this is dynamic motion blocking. Then dynamic traction splint. It offers traction to a joint and allows controlled movement only. So if you can see the example, uh, a little finger is attached to the splint here through the wires to both the rings. So only motion is allowed in this circular motion. Only flexion extension is allowed. Abduction adduction is not allowed. So it is limiting the motion. So also it is applying continuous traction. If you can see, it is continuously under traction. It is pulling the finger apart. That is moving the joints apart. So that is offers traction to a joint, allows controlled movement only. Third, tenodesis splint utilizes active extension of wrist in C6 tetraplegic patients to produce controlled passive flexion of fingers against a static thumb post using a principle of parallelogram, or you can say passive insufficiency also. When the patient goes for extension of the wrist, at that time there will be flexion of the fingers, digits. This will be possible by tenodesis splint. So it is mainly used in C6 tetraplegic patients to produce controlled passive flexion of the fingers against a static thumb post using the principle of parallelogram, that is wrist extension producing the flexion at the fingers or digits. Some contraindications of orthosis, when you should never give orthosis. The first thing is severe deformity. If the deformity is out of control, the deformity has reached to the bones completely and it is not possible to recover at that time, you should not give orthosis. Second, if it limits the movement at other normal joints, for example, elbow is affected, but limiting the elbow also limits the wrist, you should not give orthosis. You should only give orthosis for the part that is affected, not the normal joints. Third is skin infection. If the skin infection is there, ongoing skin infection is there, you should not give orthosis. It will spread the infection. Fourth, when muscle power is inadequate to perform its function due to weight of orthosis. So yes, this will you will be able to see this contraindication mainly in the patients of neurological conditions where there is flaccid paralysis. In flaccid paralysis, there is no meaning of giving any type of orthosis. Why? Because the use of orthosis is to maintain or improve, but that improvement is not possible as there is no adequate muscle power only. When orthosis interferes grossly with clothing or limits one's style of living, so this is subjective to such patients whose style of living is as such, the orthosis cannot be used, very subjective. Lack of motivation or the psychological problems, if the patient is not psychologically stable, there is no meaning of giving orthosis, it will not produce its role that is supposed to be given. And very young or very old patients, yes, so very young do not need orthosis, they will regain the functions recovery is faster. That is the reason. And very old patients do not recover, and hence giving orthosis is waste of energy and finance. Last thing to be discussed today, disadvantages of orthosis. What is the disadvantage? So there is lack of cosmesis. Yes, wearing something over your hands, over your lower limbs, over your trunk uh, does not look appealing. That is lack of cosmesis. Second, muscle supporting spine can become weak. Whenever segments are immobilized, we find increased movements at its ends. So second, first, muscle supporting the spine can become weak. So when a part of the body is limited, the same left side, for example, left side, you are limiting the shoulder or limiting the elbow. So you will be using mainly your right side for all day-to-day activities. And hence left side spinal muscles will also get weak because they are not used for stabilization purposes. Third, whenever segments are immobilized, we find increased movements at its ends. So, for example, if elbow is immobilized, left side elbow is immobilized, your wrist of left side and shoulder of left side will work more and more to compensate the motions of the elbow. Yes, whenever the hand is used. Person becomes psychologically dependent on it. Patients often think that orthosis is the only key. They can walk, they can do activities, and hence they become dependent on it with time chronically. Reduction in bone density. So as the part is immobilized, it is not allowed to do motion. When motion is not done, there is no force produced in the bone. Because there is no force in the bone, the calcium reabsorption from the blood does not occur, and hence the bone density decreases. And skin alteration or calluses at patient orthosis interface. So if the orthosis is not designed according to the measurements of an individual patient, it can cause pressure at some areas, itching, irritation, and directly leading to ulceration. So today we discussed about what are orthosis, which are the upper limb orthosis. We discussed the principles of orthosis. We also discussed about the classification and biomechanics and contraindications and disadvantages of orthosis. So hope this is clear to you. We'll continue the same in next forthcoming lectures, and we'll be completing this in probably one or two more lectures. Yes, so have a great day. Take care. Be safe.